Right, so just to introduce the session, so this is around waiting list equity analysis and the tool that we're in the process of building or iterating on. To introduce myself, I'm Matt Eves, Population Health Management Specialist, and I'll just hand over to James to introduce himself and take us from here.
Thanks, Matt. I'm, as it says there, James Chisholm, Head of Information and Performance. So I head up the analytical and business intelligence functions within the Trust. So what we're going to talk through today here, you can see the session agenda. I'm going to give a brief bit of background to us and the work. I'm going to hand over then to Matt, who's going to give an overview of the logic that we've used. And then, then we're going to talk through, so what's the impact that it's going to have? And we very much kind of want this to be a fairly interactive session within the bounds of the time that we've got. But it'd be really useful to get kind of experts around the virtual table to kind of input on that. And I think your questions allude to that as well. So thank you, Rachel. And then we're going to talk through the other potential use cases. We're talking about a waiting list equity audit here, but there are a plethora of other use cases that we could apply it to with the appropriate data and resources available. Very brief summary of other work in progress, and then we kind of get into the meaty, the fun of the agenda, which is the demonstration and the tool that Matt's developed. So that's the kind of overview of what we're going to do today. I was just going to give a bit of a background to us very briefly. So obviously we're a community provider. We provide community services across the length and breadth of Derbyshire, primarily domiciliary based services, but we do have a lot of plan care services, and the plan care services is kind of what we've been focusing this work on, around elective recovery essentially, and where our services are at. We also have inpatient bedded care for rehab beds. We have some mental health services, and we also have some urgent treatment centres. So we've got a sprinkling of everything, and we also host 4 GP practices as well. So we've kind of got a bit of a mixed bag in terms of what we provide. In terms of us as a core team, just very quickly, we're kind of small but perfectly formed in my eyes. So we've got five analysts within the team, headed up with a senior analyst that heads up that team, and we've got 3 members of the BI and data warehouse team. So as I say, a fairly small team, and I kind of wanted to bring that context to this call because there's a lot we want to get done, but again, a lot of it is around the resource side as well. But Matt will go on to talk about some use cases where we've freed up a bit of capacity by using some of this technology as well. And in terms of the systems we use, I think this is important as well. So our core EPR is TPP System 1, and the core source for this piece of work has been the community module of TPP System 1. We do have inpatient modules, we have urgent treatment centre modules as well, and mental health modules, but for the purpose of this, it's purely around the TPP community module and how we're kind of managing community waiting lists. We do have Inform, which is a sexual health system as well, but 95% of our services now use TPP System 1. But that's just a bit of a background as to who we are and the kind of systems we use. So we started on this journey around waiting list analysis quite a while back, and we developed some BI dashboards. So our incumbent BI platform is called MicroStrategy, but we're now currently on a migration path to Power BI. So what we've developed on MicroStrategy was analysis of waiting times, and it was to respond to the CHS waiting list sit rep, and it was a very, very high level. And we also had a mandate, and other providers around the table will probably understand this, that we had to start reporting waiting lists and also an element of health inequalities via our board performance report. And at that point, we didn't really have the kind of depth of intelligence around the profile of those waiting lists. So the BI team and analysts developed a dashboard. You can see a redacted screenshot of that, but effectively where it's got the big orange service lines, each of those is our individual service lines that carry a waiting list, the size of those waiting lists, and critically, the difference between the waiting times, the open waiting times for people from a white British ethnic background to people with other ethnic backgrounds. We literally did a kind of, we grouped all other ethnic categories together to kind of give a comparison view, but we know there's a lot more depth that we can do to that analysis. And this kind of provided us with the first view of what our service waiting list look like in terms of that profile, and it then threw up, I think, the next bullet point, Matt, if you just want to run along the timeline. Started to look at some real outliers. Now we know we've got some services with big waiting lists, but when we started to drill into those characteristics of those waiting lists, that's where it really started to open our eyes as to where some of the discrepancies were. So we started to kind of look at that in detail, and that then led on to another piece of work, which was a bit of a kind of deep dive into one of those service lines, because we did have one service line. It's probably not as clear on that chart that you saw before, which had a huge waiting list and a huge discrepancy between people of different ethnic backgrounds, and there were some kind of hypotheses that we were throwing around about why that could be, but that then started the work between ourselves and Matt with his role to kind of have a real look into that and find out what that's looking like. So we did that piece of work. We shared that work with the service. Critically, we shared it with our EDILF group, which is our equity and diversity group within the trust, and started to get some traction and engagement through that group in terms of the work that we were doing. At this point, I think I'm going to pass back over to you, Matt, if that's okay, to talk through the next bit.
So separately to this work, another request sort of came through for some support to look into waiting times around August this year, looking at patients with a learning disability and/or autism, and whether or not they were waiting longer than patients without. And this was an assurance question that came up through one of our governance committees via EDILF, actually, as James has just referred to, and it related to the LD&A standards, which have become mandated recently. So, just 1 second. So at this point, this work was undertaken and a response provided, but actually it prompted a thought, which was maybe we could look to scale this a little bit more and beyond LD and/or A patients. So started to develop the first iteration of the tool, which was just to replicate the online odds ratio and relative risk calculators that are easily available, functionality only. So at this point, it was really just to replicate what is already available, so no efficiency gain at this point. Did a little bit of stakeholder engagement, got some thoughts on that, and then iterated that once more. And this time we started to incorporate statistical test functionality, so going beyond those online calculators, and started to look at logic checks to ensure we use the appropriate statistical test here, and then start to build in categorical analysis for waiting times. Bit more stakeholder engagement around that approach, and that led us to a third iteration, which was starting to not only run all of these things for the whole trust, where the assumption at this point was we're passing in a data set for the whole trust waiting list, but also run the analysis for every service level within that data set. And where we are now is further stakeholder engagement, only this time, while we've got a few snagging issues to resolve on a technical front, mainly we're now starting to think about how do we use the output from this, how do we turn this into action. So a lot of our engagement at the moment is focused on that and less around the technical side of things. And it's worth noting this has all been a bit ad hoc and in between other priorities, so it's very much progressing where time allows. So a quick overview now of the logic, and I thought this might be useful in terms of when we run the tool in the min, we can see what's happening. So anything that's got a blue outline is just a user interaction. A green outline is a button or a trigger. A red outline is the program itself undertaking the analyses or calculations. And a grey rhombus, presenting to somebody else, they saw that as a diamond, so grey rhombus or diamond, decision points in the program. So initially, the data is selected from the user, from the relevant folder, and you have the option of running, as I said, now for all services. If you select that option, There's a little bit more setup. So you select a field containing the service labels, and then what happens is the main data set is subset into all n number of subset data sets for the number of services present in that label. And if you don't do that, or even if you have, the next step is selecting the column from the chosen data set containing the exposure label. So going back to the original start of this work was to undertake an odds ratio and relative risk. This is to start to build the components of those two measures. So select the exposed and unexposed labels, and then similarly the good and bad outcome label. So in our case, using this for waiting times, that's waiting above or below a certain threshold point. And then automate or calculate, the odds ratio, which is then undertaken. So first off, the program splits the data set into two, those with the exposure, those without, and then subdivides that into two further sets, so those with the good outcome and those with the bad outcome, and then uses those to create the components for the odds ratio and relative risk using these formulae here, and then repeats that for however many services there are present if that option's been selected. Then there's a little bit of subsequent setup in terms of selecting a continuous variable of interest. So in our case, waiting time in weeks, and the categorical variables of interest like gender, ethnicity, etc. Then a button which then triggers the statistical test logic checks to happen. So at this point, the data split into two data sets, again for the exposed and unexposed group. And the test is whether or not the continuous variable of interest is normally distributed. And what happens here is if one or more of those is not normally distributed, then a series of transformations are tried to try and make it normally distributed. So the first is the natural log transformation, and it checks if it's normal, and if it isn't, then it tries the next one. So it then tries a square root transformation, and so on, and so on. Now, if at any of these points the transformation has been successful and it's successfully converted to being a normally distributed variable, then this loop aborts. Or if it was normally distributed to begin with, then the parametric test assumptions are checked. So the first of these in the program at the minute is, does the categorical variable have more than two levels, sorry. If it doesn't, then a two-sample t-test is run. If it does, a subsequent check is, there equal variance. And if there isn't, then a one-way action over is run. And if there is, then a one-way over is run. Now, alternatively, if the data wasn't normal and none of the transformations have worked, then the non-parametric assumptions are checked. So starting with, similar as before, are there more than two levels? If there are, a Kruskal-Wallis test is run, and if there isn't, a Mann-Whitney-U test is run. And then that repeats just as before for every service that is present, if that's the option that's been selected. And then finally, a Kaplan-Meier survival analysis is undertaken. So this at the minute is run for the whole data set, not the service level. So in our context, we've been using a full trust data set. So split it into two series, one for the continuous variable of interest, one for a field indicating whether or not the patient has left the waiting list, and then fit the model for those two curves. This is an example output here, and it's showing you, in our case, we ran this for LD and A patients and those without, so it plots this. This may or may not be familiar, so just in case it isn't, what this curve shows you is the probability on this axis and time increasing in this axis. And it means at any one time, it shows you the probability that you'll wait longer than that time. So at time 0, you've got a certainty, a probability of 1, that you're going to have a waiting time that's longer than 0 weeks. But as time progresses, your probability reduces because people start to get seen. And so it plots the two groups together and with confidence intervals, and it subsequently runs a log rank test to test if there is a difference in that probability spread, for want of a better word. And then finally, it presents these results to the user. So here's an example. I've just talked through the chart, the chart here, but there's also a table that's pulled together. So any of those stats tests I talked about before, by service line, if for the given service, at least one of those tests is proven to find a significant difference, then this summary table is populated for that service, and it indicates with a tick which categorical variable was found to have a significant difference for that service. I've run this with two variables here, but if you run it for more, then you also have additional columns with additional fields. So in terms of the so what, we sort of see this very much as through the lens of a bit of a continuous improvement methodology. There, as I'm sure everyone on this call is aware, there's many and many of these, so I'm not going to go through all of these different things, but fundamentally in a sort of feedback loop, and there's something about using this now to sort of audit and or re-audit to identify groups experiencing this inequity. I'm sorry, I've just got a message to reboot my computer, a bit ill-timed, and then lead to targeted patient engagement. So with the identified groups, so we can identify, hopefully the aim there would be to identify barriers, perceived and real for those groups, and then inform possible solutions that could be led and informed by those groups. Now we in DCHS have got a team that we link into with our local authority partners called Psychological Insights Team, where they also have a health literacy officer. So where some of this work starts to indicate that can really shape, our engagement approaches at this stage. But we also have partner agencies that are very well placed in terms of their connections into communities that we'd like to explore. Beyond this point, we can then prioritise and then implement and then repeat. And this is where this benefit starts to come in, we thought, because this isn't a repeatable, scalable, auditable method. So currently, one of our limitations, I think, in this sort of work is it requires, James talked about our service lines earlier on. Let's say we have about 40 service lines, depending how you cut the cake. It requires at the moment every one of those 40 to have the sort of capability, capacity, and awareness of these things being a possibility in their waiting list. So there's something about all those three things needing to be true across 40 different service lines. So we're trying to sort of think about how can we use this approach to flip that model and run this analysis, find this insight, and then use that to be a bit more rapid and in our approach to then what can we do about it. So it's a bit of a culture shift, really, that suggests, and it's a bit of a paradigm shift in terms of how things are done recently, which is why our engagement at the moment is very much around and working, sort of talking to people who we think would be well placed to suggest and steer and help us formulate our thinking in terms of what that next step might look like in terms of number 2. Other possible use cases, so with the caveat that obviously using it in other cases might need domain knowledge or contextual knowledge to interpret the findings. We thought it could potentially be applied to anything involving a continuous variable by categorical variables. So abstracting that a little bit, could be something like identifying groups experiencing inequity in the time taken to heal or achieve a successful outcome for a given service. So people on this call might be aware that there's a 3-part focus really in terms of equity certainly in healthcare, in terms of equity of access, equity of experience, equity of outcomes. And so in this example, while we focus so far on equity of access, we could apply this to equity of outcomes or reviewing other process measures. So like quit smoking within N weeks, lost X% body fat within N weeks, received a flu jab in N weeks of starting a campaign, achieving a treatment goal in substance misuse within X weeks, or discharge from A&E within X hours, for example. Quick canter through some other work separate to this that's in progress. Currently working through converting some previous work into a web app format to automate health equity audit, some emissions modelling and some DNA work, which is just in progress. And some work that's recently been completed is looking at modelling the effect of adding or removing one or more clinic locations to an array of clinic points to determine the effect on access by various means of travel. That one's finished but not yet published, so it will be in due course. So I'm just going to pause there for any questions at this point before we jump into the demo, if that's okay.
Yeah, sure. Thanks, Matt, and thanks, James. So there's just a couple of questions so far on the sort of, I posted in the chat for those that can see it, and I'm saying it now so everyone knows. I put it onto the Menti question for ask you questions, so people are able to do that. So what have we got? There's just 3 points here, so I'll just read them out. So first one was it difficult to identify which services used a waiting list versus caseload? And then the other two are, I think one of the second one I think you've covered, but it's really important, so I'm going to say it again. So who is the intended audience for the tool? And I think you've covered that, but that is definitely a work in progress, isn't it? Because it depends what they do with it. And then, of course, there is a question about data quality. So was there a data quality issue or issues, and how did you overcome those?
Yeah. Do you want to take the first one, James?
Yeah, I was going to say I can take 1 and 3, and then Matt, if you want to chip in with 2, although I do have a bit of an update on 2 as well. So the first question was, how did you determine waiting list? Was it either via waiting list or caseload? That's a really good question, especially when talking about System 1. So we, at the minute, we focus this on, as I say, our elective care services, so our clinic-based services, and all of those services use the RTT functionality within System 1. So the RTT functionality is what we use to underpin this, but there's no reason why you couldn't use the other functionality of System 1 around caseload, around the time between, referral to now, where there's been no appointment or anything. But yeah, our methodology has been purely around clinic-based services for now, and that's what we've used. In terms of data quality, absolutely. We're talking about ethnicity here. We know what that's like in terms of the recording of that. So we kind of, as we saw at the start, we kind of had the breakdowns of kind of white British and everything else, and then there's two more lines on our chart which is not stated and not known, is a lot higher than we'd like it to be. So that is constant communication through our own internal organisational sort of mechanics, if you like, but also where we've got the challenge that we've also got, as others will be aware, using System 1 or other joined up systems, is that when we do kind of share the record, we drag in the ethnicity from primary care, and sometimes that can be not as per the national kind of list. So yeah, it's an ongoing issue, but this has helped us kind of at least address some of those issues in a bit more detail. So yeah, absolutely, data quality is fundamental, as it is for everything that we do. Matt, do you want to pick up the kind of audience
Yeah,
question?
Really. So at the moment, the audience is sort of very much geared around, because it's sort of running locally, geared around a technical audience, but the intention is to split the audience. So the running of it is very much different to the who is the intended audience for using the outputs from it. So that's why currently we're focusing on engaging with people to look at, okay, well, if we were to share the outputs from this, how would these resonate with that group, and how do we then transact a call to action as a result of using those outputs, as opposed to, so I wouldn't be expecting a non-technical audience to be using this tool as it is, but the intention is to have a technical audience use the tool, but have a non-technical audience use the outputs from it, if that helps.
Just I guess just to add to that, Matt, and we might have come on to this in terms of concluding, but we are kind of, we have within our ICB, we have what we call the SIG, the Strategic Intelligence Group. I'm sure others have, that kind of forum where intelligence leads across the ICB come together. So we've kind of presented this to them. There's a lot of shared interest. There's a lot of expertise out in the wider ICB that are doing this. So we're kind of bringing together a community of interest on that locally to see where we can kind of take it beyond the boundaries of DCHS services and looking at it at pathway level, which I think is where we'll get a lot of kind of leverage for this and a lot of benefit, and also in parallel to that, we're kind of linking in with the ICB with delivery and transformation boards, because obviously a lot of the strategic planning, I think this has got a huge potential to kind of support that planning at an ICB level.
Yeah, absolutely. I was thinking looking at the whole pathway, that would be of interest and so relevant to many more people out there across health and care. I think you have to start with looking at what you can look at and get the processes working, trust what you're seeing, and then sort of bring in those the other parts of the pathway. When we did the work, when Stephen Wyatt did the work on inequities in access to elective care, 2021 now, across 4 particular areas, there were clear differences, from GP appointment to right way through to elected procedure on where those discrepancies changed, for example, just looking at social inequities. So that the whole pathway would be of interest. What was the name of that group that of analysts, James, that you have that sort of
yeah, well, it's called we call it locally the SIG, so it's a System Intelligence Group or Strategic
okay.
Intelligence Group as it used to be, and it is basically intelligence leads from provider organisations, both community, acute. We have EMAS, the ambulance service. We have the 2 local authorities on there.
Okay.
Yeah, and the local CSU as well, and the ICB. So it's a kind of it's a gathering of like-minded people that are kind of tasked with sort of pulling together the intelligence requirements of the
that sounds
ICB.
It sounds a bit like your intelligence function, but I don't know whether it's sort of called that or whether that might sort of, I don't know whether you have something different which is called
essentially that. It is.
Sounds like it is.
Yeah, the kind of its remit is fairly loose, but it is forming in terms of tangible actions for that group, but it has been a kind of slow burner.
Yeah, that sounds good. Thank you. So I'm aware of time, but there are 1 or 2 other questions I could just quickly fire at you because they've just arrived, and I think they're fairly quick for you to answer. So I'm going to take the presenters privilege. I've just made that up. So a couple of them which you will cover anyway. One of them is, and I'll just read them out. One is the code available on GitHub, or is it available generally? That's the first question. Second question is of 3 is do you have a research evidence team to link in with to triangulate your data findings? So your point, Matt, about the intended audience for this, obviously there's a translation between that and the people who are going to use this and change the way they do things over time as well. And then the last of these final 3 questions is, what stats expertise do you have in-house? Through the process that you've described so far, there's quite a lot of statistical tests that you've mentioned, which will be done by Python, but you need to, in the way that you've done it, but you need to know what's being used and why, that kind of thing. So
yeah, it's quite a lot to get through there quickly because I'm conscious of going on.
Why don't you just pick one? Pick one.
I think well, the easy one is the code available? It isn't yet, but the intention is absolutely to make it available on GitHub. So that's that one. The one around stats expertise in house, I think there's what I'm part of, like this sort of conversation. I'm really keen is to, because we're sort of pulling together the logic, we're pulling together the tests that can be done using the programs and libraries within Python, and making a logical connection. But I think there's a piece here, the UAT piece of this, which not just on snagging the bugs in terms of functionality of making it run, but also just validating those sorts of logic checks. So I've started to engage. We host a couple of specialty registrars with us, and so I'm starting to engage with one of our specialty registrars to work through that together, because I think it's really helpful to have a fresh pair of eyes and an informed pair of eyes to start to validate that. And I missed your third question, but I've forgotten it.
It's essentially around, do you have a research evidence team to link with to triangulate your data findings? So it could be this the team that James has described, or it could be different.
Yeah, so we do have a research team, and coincidentally, I've literally messaged them this morning to say, can we have a chat? Because I'm really glad that question's come up. So yeah, it's sort of starting to have that initial conversation around this is where we're up to, this is where we're going, and how can we, how can we leverage your expertise to help with that? So yeah, absolutely. I'll if that's all the questions for now, I'll start sharing from here. Now, hopefully that's coming through.
Yes.
Excellent. And so what I've got here is just like it's all on one page, just one landing page. At the moment, I've just hard coded a reference to some demonstration data, but the idea is you could select the data set here. As this is sort of hopefully now resonating a bit from that process map, so selecting the field that contains the waiting times, so that is weeks waiting in this case, selecting the field that contains the labels that indicate whether the wait is closed or is still open, so that is open closed, and then selecting the label that indicates that the wait has been closed, so that is closed. And this is just populated with all unique labels that are in whatever column we've selected here. And then this just enter the given waiting time threshold in this current use case, so let's say 18 weeks. And this is the option for running for all services. Now, if we run for all, we need to tell it what field contains the service labels. So in that case, we need to drop in here and just say service name. And this little drop down gives you a preview of all the service names. I've redacted them for the purpose of demonstration, but there's 19 different service names in this example. And then set up the odds ratio and relative risk components. So exposure, in our case here, just to mirror the process example, LDRA. Exposed, meaning in this case they have LD, the patient does have an LD and or a diagnosis, or not exposed, so it doesn't. And the outcome would be, did they wait less than the target? Now this variable was created when we chose the threshold here. So we chose an 18-week threshold, and now there's a binary variable that indicates true, that waiting time is less than the 18-week threshold we chose, or false if it's not. And then we select confidence interval and run the odds ratio and relative risk. So that then in blue here gives us a trust position. So it suggests that with an 18-week threshold, there's a significant difference between the odds in the exposed and not exposed groups, but also a service level finding. So what this shows you here is of the 19, so try to keep some sort of plain English summary of what's going on. So of the 19 services, the odds ratio could run on 6, and that would mean there's a logic check there, which is whether or not one or other component of the odds ratio was 0, in which case it doesn't run and skips to the next one. The below table summarizes significant findings. So this table is the service level, which service has a significant finding, what that is, and the interpretation. So it's the interpretation currently is a bit of a double negative. So where it says odds were lower in the exposed group, it means in this case, people with an LD and or A flag on that record have a lower odds of waiting below 18 weeks, or have a higher odds of waiting above 18 weeks. So it's a bit of a double negative one to fix in terms of how this is communicated. But if you drop down here, what you see is all 6 services that this was run for, their respective results, the interpretation for all, and again, that one's just repeated there, service C, for that significant finding. So basically this subset up here pulls out any significant findings, and this is all the findings. Relative risk and the service level relative risk is just afterwards. And then determining the appropriate statistical test. So reselecting at this point the week's waiting, so this could be skipped as an improvement. We've already selected it above. And selecting the categorical variables to include. So our example in the slides had gender and ethnicity, so let's just select them. But as and when, whichever ones you select, if you drop this down, we get a little data validation check, which sort of says, well, the fields you've selected, this is the count and these of each unique label in that field. So in ethnicity, this is the count of each unique label in that field, and as you can see, not known is our second highest group. Now, an area for development here, which isn't yet coded, but isn't yet finished, but is part coded, is to have the option to run this as is, but then rerun this with potentially removing, say, that not known, and then rerunning to see a sensitivity effect of that. So it might mean that we could deselect I there, for example, and then run for F and M labels, and then seeing, because that will then trigger a different test. There'll be a warning currently because this is 2, and that'll come up in a moment. That's still to be finished, but hopefully gives an idea of that sort of ability to consider those data quality points at this point and where we're heading with that. Then what happens here is that slightly complicated slide, which is looking at, tells us at least one group's not normally distributed, so it tries actually running 4, not 5. That's a typo, apologies. Transformations, and then tells us that none of those are successful, and so non-parametric tests will be used. It's then run the checks for those, and then summarizes what it's going to do here. So it says for gender, it's going to use this test because the independent variable has more than 2 levels and the parametric assumptions weren't met. And the same for ethnic category. Those tests are then run, and then the result, it gives us a warning here, because as we saw above, not all groups report 5, and tells us if a significant difference was found. Same for this one, and it'll just repeat for each test we run, for each variable we selected, so each categorical variable. And then all services, this summary table, so of our 19 service starting position, which services returned results for each field. And then finally, the Kaplan-Meier survival curve, which I think, to be honest, in hindsight, could be reordered to be below the odds ratio and relative risk, but is currently here. And it just shows you that actually when this test is run, while the odds ratio with a cut-off point of 18 weeks shows a significant difference, once you look at the probability across time between the two groups, there isn't actually a difference that was detected overall. And that's where this work is, where it's currently at. So I'll stop sharing there. Very happy to take any thoughts or comments.
Okay, so I've got no further questions on the on the Menti. But thank you very much for that. So we had a chat about this before, didn't we, Matt? So this is very much a work in progress from your perspective. So you're involved with different things, and it's not the only thing you're doing. You're doing all sorts of other things as well. But I think so. One of the questions that you had before, so if I just sort of flip back to those 3 sort of questions, which we can't sort of probably go through. People need time to think about some of the things that you've covered. The 3 questions that you asked before were you were asking people's views on any particular features or components that they liked, and you're asking why any of weirdly I've repeated the same thing twice. Sorry about that. I just realised. But essentially, you're wanting feedback on the tool itself. You were asking if anybody was interested in you sharing the code with them, and you were offering, this is my interpretation of what you said, you were offering to support them to take this forward as well. So that's kind of like an open offer. So I think people can contact you. I'll share your details afterwards. And yeah, so when we were talking, thank you very much, James. That's very good. Sorry, I just placed an order rather cheekily from a colleague who is not my assistant or my husband. Anyway, yeah, so I think this is really useful. The things it does, it's a tool that can be deliver results quickly. When it's been tested, tried and tested, and you're confident with the data quality and so on. So it delivers results quickly and is robust, subject to data completeness and so on. So there will always be that sort of element of interpretation. So once that is, and you can get people on board with helping them to create the tool for themselves, the data sources routine and so on. At the moment, it's that what do you do with it, isn't it? So it's that real key question that you're working on, is how can we get this information, the right information, to those people who can make a difference. And when we chatted, we talked about how long that might take for this to be sort of a systematic approach to how a particular service reviews their waiting list. So at what point in the cycle do they look to see what the inequities are within the current waiting list, and what do they do about it? So it not only changes the way that they receive information, it's then having to change in some cases fundamentally what they do with that information. So that's where the impact will have, and that could take a long time, but it's definitely worth persevering. So thank you very much for sharing that.
Rachel, sorry, just to kind of close the loop on the kind of the so what bit as you described there. So
yeah.
So looping right back to the start, when I mentioned that kind of the board performance report was the area that we started to get a mandate around health inequalities. We've now looped that round, and this month we are going to add this information into the board performance report, so our board will see it. And because it's already been through our eDILF group and service leads on there's now awareness of where we're at with that. So I think that will get a lot of traction, because it will be under the noses of our execs, and they will be asking those questions. So it's that's kind of one of the so what bits is it's happening now.
Yeah, that's absolutely, and that's the way to do it, isn't it? And it's always it's often a timing thing. If something is presented or people are made aware of something and it's the timing isn't right or it's not quite at the right level, then that doesn't work either. But that sounds great. Andrew's mentioned in the chat that it's nice to see work that is in progress and not just waiting until it's done. And I would wholly encourage people to share work in progress, because it can help you. It can help you progress that work when you get feedback and input from other people as well. You see things when you're in something, you see in the bit that you're doing, and just to have from others, it can be very, very helpful. And also you can share what you've done, and it's a sort of I mean, this to me it looks entirely polished, but you could, it's not it feels like it's not a warts and all kind of thing, but equally we can see that the way that you're describing it, there's definitely things that you want to tweak and want some input on as well. That's really helpful. Okay, are there any other sort of final points that you two would like to say before I sort of move on to one or two Huddle ending bits?
Only if anybody has any thoughts or suggestions or areas for improvement, really welcome those. So yeah, please do get in touch, because it is a point in time and we would like to iterate it further. There's a couple of bits we're aware of, but there'll be bits that we're not. And so if there are any suggestions for improvements, I'd love it if somebody would get in touch.
That's excellent. Thanks very much. Well, I'm sharing my screen again. There is one final question, but I'll just have a quick look to see if it's. Yeah, great to see work in progress. Must be some public health analysts and consultants who would be interested to help peer review. That's a very good point. And then someone gave him some a link to some examples, so for you to look at later. Thank you. So thanks very much both. I'm just coming back to Menti. There's just a couple of just I can't say how much I do appreciate. Sometimes I feel like I'm being flippant, but I'm so appreciative of your time, and I know it takes time to pull something together to share with others. I like to think that it helps you, because it helps you crystallize your thoughts. It helps you bring things together, and I like to think that it actually can sort of benefit you in your work as well. So just finishing off, sort of, if you hear anything in the background, it's Jack Roper. Anyway. Coming up in the next few huddles, we've got Andrew Jones. These aren't in order, but he's going to be talking about his work around community services contracts. We've got Stephen Wyatt, so another strategy unit contribution, and he's going to be talking about work around need, demand, and supply of general practice consultations. So this is something that he talked about in summary at Hacker in July. Our next huddle, I think, is about social care data. So I would very much like to see a whole range of analysts and others from health and care on that one. So this is talking about and raising awareness of the client level data in a way that you may not be familiar with. Obviously, client level data has been around for a long time, but I think that's definitely worth coming to with Ross Bailey and his and colleague. And then we're going to be I'm really keen for us to talk a little bit more about intelligence functions and how they are operating and where we're at with them. We're going to be this kind of thing we're going to be talking about this afternoon in this session here, because I think it's something that people maybe could do with knowing a little bit more about and seeing where they fit with them or not. So in terms of the training that we still have available for you too. We had a very busy September, and October was busy too. So we had a lot of courses starting. There's been a lot of sort of training activity. Now, this is one we've talked about last couple of times. So this is the creativity and analysis. We love the sound of this one, don't we? Some people will be saying, no, this is not me. This is not for me. Others will be, absolutely, this is something I want to be involved with. So there's a few places left on this training workshop, which is sort of just at the strategy unit offices, which is just a couple of minutes from New Street. And but if you can't make that date or that location, if you could complete the form anyway and pop yourself on the waiting list, that would be really helpful for us to kind of measure the demand for this type of training, and it's not on the waiting, it's not on the form at the moment, but if there's some people have contacted me separately saying could it be somewhere that isn't Birmingham, and of course this is something that we can consider as well, because how it's not necessarily equitable for us to have training here all the time, and we do try and move around. Okay, so do have a look at that. There's about five places left on that one. And there's 1 or 2 online courses, so understanding variation. I've just mentioned the creativity analysis workshop, which isn't online, and then introduction to Git and GitHub with Zoe Turner, who I think is in the room today. In fact, she definitely was, might still be. I've been going through. I've been having going through a really lovely process of collating feedback from all of our training for sort of an evaluation that we're doing, and really lovely comments. And Zoe's training always gets fabulous responses as well. So do have a look at that if you're interested in learning more about Git and GitHub. And then there's Fraser Batty's Thinking Tools workshop, which is here at the studio in Birmingham, but they do very nice pastries, and it's so convenient for New Street, and again very well received workshop, and a good use of your time as well. So I will stop sharing. I will come back to the room, and I will. I've got 2 minutes. So this is me, and I'll finish now. So thank you again, Matt. Thank you again, James, for coming today, and for everybody in the room as well. And I'll see you all in a couple of weeks. Bye bye.
Rachel.